Okay. Hey, everybody. Again, my name's Dr. Lyle Pavuk, physical therapist over here at Sharp Coronado. And I want to thank you guys for taking the time to listen to this presentation I put together. This is a lecture I've given quite a number of times in different venues throughout Coronado, particularly. And the title of this lecture is Muscle and Joint Pain, A Better Understanding and Steps to Manage. And we're going to really dive into some of the science of pain and how it works and give you some management strategies to, one, try and prevent the onset of pain, but to the other side of that is to manage it better after the onset. I'm going to start with just some of my professional qualifications and my education. And again, if you've been to some of my presentations, I always start with my personal mission statement, and I try and live up to this every day. I practice in the clinic, and my mission really is to empower others to take control of their physical and their mental well-being in order to live their best lives. And it's just so important that people understand the power they have to help manage their health and to optimize their health with different health behaviors such as physical activity and exercise and a healthy diet and practicing good sleep habits and things of that nature. So, we're going to talk about some of those concepts throughout this lecture as well. My educational background is that I have a Doctor of Physical Therapy degree from the University of Miami in Florida. My bachelor's degree was in secondary education, specifically in English and language arts. So I was an English teacher prior to becoming a therapist. I have what they call a CSCS. I am a certified strength and conditioning specialist. I also have specialty training as an applied prevention and health promotion therapist, meaning that I have a good understanding of population health and seeing the health of a large group of people and how you can change the outcomes of the health of a large groups of people. I'm also practicing DPT at Sharp Coronado Hospital, as mentioned before. And I think it's also important to note that I also am a chronic pain sufferer, and I've had many pain problems in my life, so I can empathize with the experience of my patients and those around me. Let's talk about our learning objectives for today. So number one, it's important that we establish a better understanding of the prevalence of muscle and joint pain in the US. We're going to learn more about the science of what pain is, and more importantly, what it is not. Number three, we're going to talk about prevention strategies to reduce the likelihood you and a loved ones will experience muscle and joint pain. Number four, we're going to talk about what you should do immediately after pain onset or a new injury. And then the last thing, number five, is when you should seek medical attention immediately and which circumstances might that be important to do that. All right, let's talk about the prevalence of musculoskeletal disease, or in other words, muscle and joint pain. So about 50% of US adults report the presence of musculoskeletal pain at any given time. And that's pretty even amongst the genders, but it's about 47% of men and 53% of women. So you can see that this problem really applies to all of us, because that 50% is just at any one time if you took a survey of the US population. And only in very rare circumstances are there people who do not experience pain. Just some more prevalent statistics. So nearly a third of US adults report having chronic joint pain. That is, that it's ongoing and persistent pain. The most common of which is low back pain, followed by arthritis. And then neck pain is also quite prevalent. And even at 11%, people have radiating leg pain, which is, if you've ever experienced, can be quite debilitating and a challenging thing. This slide is basically depicting the different types of medical issues people could have and the prevalence of those issues. And you can see musculoskeletal issues are by far the most prevalent, even more so than circulatory or heart issues, respiratory, lung problems, diabetes, and cancer. Okay, so we've talked a little bit about the prevalence of pain and the reality that it really doesn't discriminate. This is a problem that we all deal with throughout at different points in our lives. So now let's start getting into what is pain. And we're going to start with the more important thing of what we used to think it was and what it is not. So what is pain? What we originally thought, and this is based on what they call the Cartesian model of pain. And basically what the Cartesian model emphasized was that, our body was communicating messages to our brain, telling us that our foot hurts. So in this example, there's the caveman and he's putting his foot close to the fire. And the Cartesian model assumed that the foot was communicating and telling the brain that, ow, that's harmful, I need to pull away. But the problem with the Cartesian model and the assumptions that came along with it was that there were quite a few examples where it didn't hold up. There were exceptions to this concept. Let's talk about some of those. The first one, and a very powerful one, is what they call phantom limb pain. And phantom limb pain is very, very common in people who have had amputations. It's actually, phantom limb pain is experienced in about 60 to 80% of patients following an amputation. So, again, that's quite prevalent. And the question we have to ask ourselves is, if pain is all about tissue damage, or like the fire touching the caveman's foot, how is it possible that we can have someone experience very real pain and very significant pain in a limb that actually does not exist? It's gone. That's one of the first questions we had to ask. And then we started to see some other studies that were bringing a little bit of a question mark to this idea that all pain is related to tissue damage. So we can look at MRI studies. And this is a pretty busy slide, and I'll try and take you through it little by little. On the top left of the slide here, you can see it's talking about neck findings. And so what they found in this study of about 1,200 subjects, what they did is they took 1,200 people who had no symptoms of neck pain. And they wanted to see, what did their neck look like on the inside, even though they had no known pathology. And what they found was that about almost 90% of the people, 87.6%, had disc bulges in their cervical spine in their neck. And even young people in their 20s, about 75% of them had disc bulges in their neck. And again, all of those 1,211 subjects were completely asymptomatic. They had no neck pain. If you look at the shoulder, in this smaller study of 53 people between the ages of 45 and 60, about almost 75% of them had a slap injury, which is basically a labral tear, a common injury for people with shoulder issues. But again, it's also very common to have this abnormality without any symptoms. If we go lower to the low back, this study of even a larger subject group of 3,110 people, 80% of people over the age, or that were at the year 50 age, 80% of them had disc degeneration, and just over a third of them had disc protrusion, which, if you don't know what that is, a disc protrusion is a very high level disc herniation. And again, all of those subjects were asymptomatic. We see the same thing in the hip with labral tears, and we see the same thing in the knee with meniscal abnormalities, where in this study, essentially 99% of the subjects had meniscal abnormality, and their ages ranged from 20 to 68 years old. Again, and none of them had symptoms. So the take home is, when we scan people without symptoms, many people have abnormal findings on imaging, and that sometimes abnormal findings are quite normal. This is just depicting that low back study again. It's showing the high prevalence of abnormalities, and even young people, 37% of 20-year-olds had disc degeneration, and 30% had disc bulging. And that number gets more significant, with 96% of 80-year-olds having disc degeneration and 84% having disc bulges. And again, we have to reiterate the reality that none of these people had any symptoms. So it's important to not only rely on imaging when we're trying to diagnose what might be going on with someone's pain, or trying to predict if pain might be a future reality. This is an interesting study they did of a group of Olympic athletes from the Rio de Janeiro 2016 Summer Olympics. And they wanted to see what the spines looked like of these very elite athletes. And so what they did was they took 100 athletes, and they underwent an MRI of all of the regions of the spine, the cervical spine, the neck, the mid back, and then the low back, the lumbar spine. And what they found was that 52% of them showed moderate to severe spinal disease. So even in these very high level athletes, many of which are, in their 20s and 30s, over half of them showed moderate to severe spinal disease. So what does that tell us? A high number of the world's premier athletes demonstrated moderate to severe spinal disease on MRI findings. So what is that? The take home that I would give you from that is that, just because we have abnormal findings on a scan doesn't mean that you can't perform at a very high level in your life physically, and be able to do the things that you would like to do. Let's talk a little bit on placebo research. So again, we're kind of dissecting a new understanding of pain and the complexity of that. And placebo research kind of gives us some insight as well. So what they did in this first study we're going to talk about, this was a systematic review, meaning they took a bunch of studies and looked at the data and kind of compiled it all so they could make some more powerful conclusions with larger amounts of data. So this was a collection of 12 studies, and they looked at a total of 49 different drugs in these studies. And they wanted to see, does the color of the pill actually affect the perceived effect of the drug and its actual effectiveness? How well does it work? And what they found in their conclusion was that colors affected the perceived action of the drug, and they seemed to influence how effective it was. And specifically that if they wanted a drug to have a stimulating effect, it should be colored red, yellow, or orange. And if they wanted it to have a tranquilizing effect or a relaxing effect, that it should be colored white, blue, or green. It's very fascinating. Another placebo research study looked at the price of a pill, or the price of a medication, and of a placebo medication specifically. They wanted to see, one, if the placebo would work, and if it was valued as more expensive, if the patient thought, or the subject of the study thought the pill was more expensive, would it have a stronger effect? And so they recruited 82 men and women and to rate their pain to an electric shock to the wrist before and after they took this placebo pill. Half were told that the pill was $2.50 a dose, and the other half were told that the pill was 10 cents per dose, so significantly cheaper. And what they found was that the pills had a strong placebo effect in both groups, but the effect was even stronger in the group that was told it was more expensive. So 85% of those using the quote unquote expensive pills reported significant pain relief, and 61% on the quote unquote cheaper pills reported significant pain relief. So either way it worked, but if the medication or the placebo was perceived to be more expensive, it had a stronger effect, which is very fascinating. Okay, this was a very interesting study done by Lorimer Moseley, who's one of the leading researchers in pain neuroscience. This study was titled "The Context of a Noxious Stimulus Affects the Pain It Evokes." What they did was, and I'll just go to the next slide, what they did, you can see on the bottom left here, the hand, where they took a cold piece of metal and they would put it on the back of the subject's hand. And they wanted to see if the subject was exposed to a red light or a blue light while they were having that cold piece of metal put on their hand, would it affect the amount of discomfort they felt? And what they found was very consistently, when they were exposed to a red light, they experienced more pain. And when they were exposed to a blue light, while the cold piece of metal was put on their hand, they experienced less pain. And you can see that general trend line going down, with the red light numbers being a more painful rating from 0 to 10, and the blue light numbers being generally lower rating from 0 to 10 compared to the red light. So again, context matters when it comes to pain. Our thoughts can affect the sensitivity of our pain response and our nervous system generally. So with these examples, and there are many more, I tried to just pull out some of the first few examples that I was familiar with, but there are many more studies demonstrating some of these concepts. basically there had to be a new definition of pain. And so the International Association for the Study of Pain, which is one of the leading international groups that evaluates and utilizes pain research to develop guidelines, their new definition was that pain was an aversive sensory and emotional experience, typically caused by or resembling that caused by actual or potential tissue injury. And so I've highlighted a couple of the important things there. There is an emotional component of pain. It's not only sensory, but our emotional state can affect our pain sensitivity. And then the other part, actual or potential tissue injury. We don't have to have actual, we can have only potential tissue injury perceived by the brain to have pain as a response. So that those are important additions to the definition of pain that was established. Okay, now let's start talking about some of the other things that you need to know about pain. Again, harping on this concept that tissue injury, while again it is a factor, it is not the only factor, and no one's saying tissue injury doesn't matter. We see it in the group of potential sources of the pain experience. But there are also many other things, such as our physical impairments and our habits. If we engage in meaningful activities, or if we begin to avoid the things that we enjoy and love, different beliefs about pain and our coping strategies and how we manage both pain and the stress and anxiety that pain can produce. There are emotional factors, and then a big one is our lifestyle and our health behaviors. And we're going to talk a lot about that today. All of these different factors can influence our pain perception. And let's talk about a helpful analogy. I use this analogy all the time in the clinic. And let's say we take an empty glass and we're going to fill it with water. Okay. So all of these different variables can add water into our glass. We can have a lack of exercise and a sedentary lifestyle. That's water in our glass. We can have sleep deprivation and a poor sleep quality and poor sleep quantity. That's adding water into the glass. We can have stress and anxiety in our life. And we can have poor nutritional habits where we're not eating a lot of fruits and vegetables, and we eat a lot of processed, high fat, high sugary, salty foods that elevate our blood pressure and things of that nature. And so at some point, it's highly likely that glass is going to overflow if we have too many of these negative impacts on our body. And it's at that point, when the glass overflows, we are more susceptible to the experience of pain or having an injury of some kind. Okay. And so it's important to remember, if you look at the bottom point on the left, our general health is a strong predictor of future pain. And so it's important to always prioritize our health for many reasons. But just another great reason is to try and help prevent the onset of pain. Another important thing a concept to understand is that pain is an alarm system. And we're going to look at a graphic right now to kind of dissect that. And so if you've seen one of my presentations before, you've probably seen this chart. It's a busy slide, so we'll try and break it down little by little. So let's start at the top left here. And what this is depicting is basically our nervous system activity before we have the onset of pain. So we have this squiggly line at the bottom of this graph. And this is our normal excited level. This is the stimulus that our brain is processing throughout the day, different pressures and different temperatures, movement, and things of that nature. And then we have here the dashed line at the top. It indicates the firing level. This is we could call it the pain threshold. So if we get enough stimulus, the brain is going to say, okay, that's way too much. That's too hot. That's too much pressure, that's too much friction, whatever the stimulus is. And then it's producing pain as a protective response to get us to act. And you can see in this status here of before pain, there's a lot of room for activity and stimulus. There's a lot of room for different sensations between our normal level and the firing level, our pain threshold. Now let's go over to the top right here, and we have after pain, after the pain experience. there is the possibility that our normal excited level has now been elevated significantly to this extra sensitive state. You can see there's much less room for stimulus and activity between the excited level and the pain threshold. So it takes less of a temperature change or less of a movement or less pressure to elicit a painful response. The good news is that there are many things we can do to try and lower that baseline back down to a normal excited level, as depicted at the bottom here. We can work that way back down with understanding pain and not having knowledge about pain, using exercise therapy, relaxation and breathing techniques, pacing strategies. Graded exposure is a great tool. We use it all the time in therapy. It's essentially, taking something that someone has trouble with. Say I have a patient who has pain in their knee with doing squatting motions. And so what we would do is we'd find a way for them to squat. Maybe they do it from a chair, or maybe they do a more shallow squat that's not as deep, and that feels okay. And then we gradually have them do more and more. Either they go deeper into a squat, or they do more repetitions, or they start doing squats with weights and things like that. And so that exposure to squatting, eventually the knee starts to feel better and it starts to tolerate that better. There are also manual therapies, hands-on things that can be done by a therapist. And then goal setting is an important one too, and many other tools. Sleep is one that's missing from this list. Getting quality sleep consistently can definitely help people with a pain experience to help them recover. So the big takeaway from these slides about pain is to understand that pain is often more about sensitivity than it is about actual tissue damage. So that when you do feel pain, it's important to remember that hurt does not equal harm. You're not necessarily damaging your body when you feel discomfort. It's your nervous system just giving you a little bit of a warning, and it with that extra sensitivity. And here's a couple examples. Let's talk about a couple of examples of neural sensitization, a hyperactive or a hypersensitive nervous system. Sunburn's a great example because, everyone's had sunburn before and they know what it's like to take a lukewarm shower after they've had a sunburn. And everyone knows that lukewarm water is not damaging your skin, but it sure is uncomfortable and it sure hurts to have the water hitting your burnt skin. That pain is very real. Another example is a sore throat. Everyone's had a sore throat from an illness or from being at a loud concert and singing along, things of that nature. And let's take a strep throat, for example. That can produce very sensitive tissue in our throat, so that when you swallow, it almost feels like you're swallowing razor blades. It's so painful. But we all know that the mechanical stress of swallowing food, especially chewed food that's very soft, is not actually causing any actual damage to the tissues of our throat. But again, that pain is very real. So those are a couple very common examples of hypersensitivity of the nerves in our body to a certain problem. Okay, so again, when we're looking at this new definition of pain, and we'll read it again, an aversive sensory and emotional experience typically caused by or resembling that caused by actual or potential tissue injury. This new definition has been widely accepted by many organizations that deal with the study of pain throughout the world, including, again, the International Association for the Study of Pain, the American College of Rheumatology, the American and British Pain Societies, the American and the Australian Physical Therapy Associations, and others as well, the World Confederation of Physical Therapy as well. So just to know that many people are agreeing with this new definition. This isn't a sort of a one-off definition by the IASP. Okay, let's talk about some general helpful concepts. Hurt does not equal harm is something I mentioned earlier. It's important to remember that when you feel pain, it does not necessarily mean that you're damaging your body. Again, if you have a sore knee and it hurts when you squat, it doesn't mean that you're tearing your knee apart. It's just the nerves are hypersensitive and they're letting the brain know, like, hey, don't go too hard on that. Okay. Thinking of the pain as an output is another important thing. So pain is not an input from your body. The caveman's foot does not tell him that it's burning and that it hurts. The caveman's brain is letting his consciousness know that, hey, your foot's in danger and you need to pull it away. And that happens very quickly. So you can think of the brain as the CEO. It's the one making the decisions. The brain is the CEO of a company. He's getting all of this constant input from the different department managers, and that can be different parts of the body, different mechanoreceptors in the skin. It can be different parts of the brain that process beliefs and emotions and past experiences. And essentially, the brain takes all of that information and it ultimately decides what issues are most important to give attention to. And so it'll decide when pain is a good idea. Okay. But again, it is important to remember that pain can often be a hypersensitive state. Uh, let's also talk about the concept that pain is context specific. So, for example, if you sprain your ankle while you're crossing the street and there's a bus that's bearing down on you, the brain will decide that your sprained ankle is not important. And so it's inhibiting pain perception. It's allowing you to survive and getting up and getting out of the way of that bus. It will actually dampen down your pain signaling from the spinal cord and things like that through a phenomenon we call descending inhibition. Okay, very important topic. How can we prevent the onset of muscle and joint pain? What you need to know. Okay, so looking at this graphic here, let's start at looking at the right side. And this is in the United States. This is what we spend on being healthy in the US. And again, this is more about the idea of preventing disease, not necessarily treating people after they're healthy. So what do we spend on keeping people healthy in the US? We spend almost 90% of that money on actual medical services. And then we spend about only 4% is spent on health behaviors. And then the other 8% is spent on miscellaneous things. But when we look at public health research and epidemiology, what makes us actually stay healthy, when you look at that research, about half of that is our health behaviors. Are we eating well? Are we exercising? Do we live in a safe environment? Do we have a quality education? And in other environmental factors too. So you look at 20% there, and how clean is the environment we live in? Do we have access to clean water and clean air to breathe and things of that nature? And then another 20% is genetics. And then only about 10% of what keeps us healthy is actual like spending on medical services. So it's important to realize there's a huge amount that's under our control in manipulating our behaviors, changing our behaviors to healthy behaviors, and trying to stay in a safe environment and maintain a safe environment in our communities. So again, the takeaway is here, we have so much power over our health, and make no mistake, this includes our muscle and joint health. The same behaviors that prevent chronic diseases like heart disease, diabetes, cancer, and chronic lung and kidney disease are that we move well, we eat well, sleep well, we manage stress, avoid tobacco and excessive alcohol consumption as well. Those are the same behaviors that help prevent muscle and joint pain. The same behaviors that prevent heart disease and diabetes and cancer are the same things that help prevent the onset of muscle and joint pain. Very important to understand that. And there's a ton of evidence. Exercise is an extremely powerful medicine and an extremely powerful tool in optimizing health. Exercise has been shown to do all of the things listed in the slide, and you can see the names with years listed next to them. Those are the research studies that are demonstrating that. So again, it helps prevent chronic disease. It has the best evidence for addressing many musculoskeletal complaints such as knee pain or back pain. It helps reduce cardiovascular disease. It improves bone health, prevents the onset of osteopenia and osteoporosis, and it has a pain-killing effect. If we look at the bottom left of this graphic here, there's an entire science. There are groups of scientists who base their lives on studying the analgesic effects of exercise. Why does exercise help reduce pain and prevent pain onset? You know, it's an interesting thing. And of course, the mental benefits. It helps with depressive symptoms and mental illness, and it can slow and maybe slow down or even maybe prevent the onset of dementia and Alzheimer's disease. Okay. So let's start looking at some research related to the values of different health behaviors. So let's talk about exercise and the prevention of musculoskeletal pain. So in this research study that was done, this was a systematic review. So they looked at a bunch of studies and pooled the data to try and come up with a stronger conclusion. So they took 40 randomized controlled trials. Randomized controlled trials are very high quality evidence generally. So they took a collection of 40 randomized controlled trials, evaluating the effectiveness of exercise with or without education to go along with it on pain, on the prevention of low back pain. Low back pain is the most common musculoskeletal problem, as we discussed earlier. So a lot of research is based on low back pain. And what they found was that exercise was effective on its own as a lone intervention to prevent the onset of low back pain, and that the effects were even stronger when combined with education. Knowledge is power, and there's no exception here in this instance. Having understandings of pain and that it's safe to move in the vast majority of instances is empowering. So giving people exercise tools and knowledge of how to manage their health helped prevent the onset of back pain. A common question I get from patients in the clinic is this fear that exercise will make them worse. Will exercise make me worse if I have a sore back or a sore knee or something of that nature? And most of all the evidence we have is that it is safe to move. Many organizational guidelines list exercise as their top recommendation to address muscle and joint pain. And this includes the Center for Disease Control, the National Institute of Health, American College of Sports Medicine, obviously the American Physical Therapy Association, and many others. Exercise, again, is a very powerful tool. And to demonstrate the concept that exercise and physical therapy should be the first thing we try when someone has a new onset of pain, let's look at this treatment pathway for osteoarthritis. And this is specifically osteoarthritis of the knee. This comes from the Osteoarthritis Research International. And basically it's saying, if you have the onset of osteoarthritic pain of the knee, where should we start with treatment? And so it goes from left to right in the most appropriate order of how to seek treatment for knee osteoarthritis. So if we look at the very left, we have non-pharmacological interventions. So that includes patient education, physical therapy, assistive devices if needed. So that could be like braces or crutches or canes or things of that nature. And then of course, exercise and weight loss if needed. Weight loss, exercise, and education are very powerful tools to combat the pain of osteoarthritis. And only if those things don't do the trick, which for many, many people, it does the trick and they really get a lot of benefit. If those things don't work, then we look at pharmacological intervention, pain medications or topical medications or injections. And if those aren't doing the trick at that point, we should consider surgical intervention, but not before the more conservative options have been trialed. Okay. Let's talk again about what exercises have been shown to help with the pain of knee osteoarthritis. Again, so the first round of treatment for someone with knee OA is that they should try exercise therapy and weight management if needed. And what this slide is depicting the many forms of exercise and physical activity that have been scientifically proven to help manage the pain associated with knee OA. So whether it's Tai Chi or walking or aquatic exercises and pool exercises and swimming, strength training is the one that I prefer most, and building the muscles around the knee to help offload it and to build physical resiliency. So walking stairs is easier and getting up and out of chairs is easier. And, cycling, yoga, and balance training or neuromuscular training are good options as well. And you can obviously take a combination of all of these interventions. Another cool study was looking at the association of daily walking with the risk of having a total knee replacement over the course of a 5-year period. Okay, so this was a very large study, and they were just following a bunch of subjects all over the age of 65, and they wanted to see if how much you walked each day measured in steps could predict the likelihood you would have a knee replacement within the next 5 years. And what they found was that for every 1,000 steps you took a day, for every additional 1,000 steps, there was a reduction in your likelihood of having a knee replacement by 12%. Okay. And if that second point there, you were 52% less likely to have a total knee replacement if you walked 6,000 steps a day or more versus those who did not. So even just walking can have a very positive effect on our joint health and significantly reduce the odds that you will need a joint replacement. Okay. Let's talk about specific exercise recommendations. What is recommended for having good general health? And that'll give us a good framework for how much exercise we might need to prevent the onset of muscle and joint pain. And these recommendations are very consistent from the Center for Disease Control, the National Institute of Health, the American College of Sports Medicine. They all agree. You want to try and get at least 150 minutes a week of moderate intensity aerobic exercise. So that would be moderate to intense aerobic exercise. And that can be in the form of brisk walking, swimming, cycling, jogging, hiking, exercise classes, anything that you enjoy and it's going to keep you moving. I often get asked, what is the best form of exercise? And honestly, the answer is always the same. It's the one that you'll do, the one that you consistently can do. Okay. The benefits of exercise largely just come down to the fact that it is getting done and we're getting the heart rate up and maybe we're getting a little sweat. The benefits are vast, as we've discussed. And the second thing, when it comes to exercise recommendations, the second point there, performing strength training twice a week and trying to focus on large muscle groups. So that includes large muscle group exercises, meaning that they work a lot of muscles at the same time. So squatting works all the muscles in the legs, pushing movements such as a push-up, which can be done on a wall or on a countertop. That works a lot of muscles in the upper body, pulling motions, and then carrying things. Just general exercises can be extremely beneficial for our health. Okay, let's talk about some general recommendations. If you're new and you're to an exercise program and you're just getting started off, let's talk about some basic tips. So when starting a new exercise routine, number one, if you feel unsure about beginning an exercise program, seek professional help. You could talk to a physical therapist, you could talk to a personal trainer, or somebody you trust and you think really knows what they're doing. It's good to seek professional help if you think it will be beneficial. When starting a new exercise routine, you want to start slow and progress steadily. So let's take a jogging program, for example. If someone wants to start jogging, you might want to only go for like a 5 or 10 minute jog that first time out and make sure that you're feeling good and you're feeling like you can recover within a reasonable amount of time. And so if you go out for that 10-minute jog and you're feeling good the next day, the next time you go for a jog, maybe you do like 15 minutes at most, but maybe you do like 12 or 13 minutes. And then the next time, if you feel okay, then the next time you do 15. And then if you feel okay, the next time you give 18 minutes a shot. So you're only adding little bits at a time. And with a little bit of patience, all of a sudden after like a month or so, maybe you're doing a 30-minute jog, and that's great. Other tips. Obviously, you want to try and warm up prior to exercise. Get the temperature, your body temperature elevated before you really start pushing yourself. Okay. And then make sure you track your progress. Tracking progress is great because it takes the guessing work out of your exercise routine. You can see exactly how much you did the last time you did an exercise, and you can try and match that or do a little bit better the next time. And it also is encouraging because you can track, again, tracking your progress. You can see how much progress you've made. You know, maybe you went from lifting a 5-pound weight to lifting a 20-pound weight, and that's fantastic, you know. This was just a quote I found very appropriate from a colleague of mine named Scott Morrison, very intelligent guy. And he said that most injuries occur from doing too much too fast after too little done for too long. And that's reiterating that concept of when you're getting into an exercise routine, just try and start small and be consistent and gradually progress slowly. And it really pays off in the long run. Let's talk about a couple other prevention strategies for the onset of muscle and joint pain. And again, this comes down to health behaviors. You want to try and make sure you get at least 7 to 8 hours of restful sleep each night. Sleep is a very powerful tool when it comes to management of pain. I have a whole lecture on sleep and the relationship between sleep and pain. If you haven't watched it, it's worth a watch. Number two, try and eat a nutritious diet consisting of plenty of fruits and vegetables and fewer processed foods. Very good general recommendations. If you can do those two things, you're going to be on the right track. If you need more specific recommendations regarding diet, if you have a medical conditions or things of that nature, I suggest you see a dietitian, and they can really help you get a very specific dietary plan that suits your needs and your specific needs. Number three, you want to avoid tobacco products and excessive alcohol consumption. These can increase the sensitivity of our nervous system because it's harming our general health. So again, things to avoid. And then also try and manage your stressors. Everyone has stress, but we want to try and manage those stressors with positive coping strategies and outlets. Exercise is obviously a great outlet for stress, but also you can use relaxation techniques and breathing or meditation, different social activities, and engaging in hobbies and the things we enjoy in life. Okay. And then to back up, to have some evidence behind a couple of these claims, let's talk real quickly about the systematic review that talks about the relationship between sleep and pain. And what they did, again, they took a huge group of studies and compiled all the data. And the conclusions they came up with regarding the relationship between those two things is that sleep impairments can reliably predict new onset of chronic pain, as well as the aggravation of existing chronic pain. So sleep can actually predict whether someone is more likely to have pain, chronic pain, as a part of their life. And then the second thing, which is very interesting, was that sleep impairment was more reliable at predicting pain onset than the opposite. It was then pain predicting a sleep impairment. So there's a bi-directional relationship between sleep and pain, but a sleep impairment is actually more predictive of pain onset than pain onset is predictive of a sleep impairment. Very interesting. And that was from the American Pain Society, a good journal. Okay, now dietary fiber intake. And when it comes to relationship between nutrition and pain, this study titled Dietary Fiber Intake in Relation to Knee Pain Trajectory. Basically, they followed a huge group of subjects, almost 5,000 subjects between the ages of 45 and 79 years old. And they followed them for 8 years. And what they found was that eating at least 25 grams of fiber a day was associated with a decreased risk of developing moderate to severe knee pain. So having a good diet with high in fiber, and you can see from the graphic there, you get your fiber from a lot of fruits and vegetables and healthy grains and yogurts and things like that. So having a high fiber diet has some evidence to show that it might help with the reduce your chances of having pain. And then stress and pain. This study was looking at, in the workplace setting specifically, the association between workplace stress and people's sensitivity to a pain pressure threshold. So they had them exposed to a pressure device, and they were trying to correlate the workers' stress level that they rated that day and their sensitivity to the pressure pain threshold they were exposed to. And what they found was a significant correlation between pressure pain sensitivity and a persistent stress condition. So if someone was consistently reporting stress at work, they consistently would demonstrate a higher pain sensitivity. Okay. So another common question, what should I do if a new injury occurs or new pain starts unexpectedly? There's a couple approaches you could take. So one is a little more uh, of an old school method, and one's a little more modern. So let's talk about the Rice principle. Is a little bit of an older model, but the Rice principle consists of rest, ice, compression, and elevation. Many people are familiar with these ideas if they have a new onset of pain. In my professional opinion, there is no clear data and research on this concept, but I would say in my professional opinion, the best time to utilize Rice is the rest, ice, compression, and elevation is if the injured body part is swollen and it's too painful to exercise it and work it. You might have to just give it some time to calm down, and these interventions might help calm the nervous system. The more modern approach is what we call the MEAT principle, which includes movement, exercise, analgesics, and treatment. Analgesics being just over-the-counter medications. So the MEAT principle, in my professional opinion, is best if there's minimal to no swelling and you can exercise with not a lot of discomfort, maybe just a tolerable amount of discomfort. It's probably best to exercise that body part, such as the sore knee or a sore back. So what should I do if I have a new onset of muscle or joint pain that is not going away? It's been, a week and it's just kind of lingering. I would say your best bet to start is to see a physical therapist. And this goes back to that treatment pathway we talked about with knee osteoarthritis. Many painful conditions, the best thing to do is to see a physical therapist. If you've never been to a physical therapist or are not familiar, let's talk about what a PT is. Physical therapists are doctorally educated, licensed healthcare providers, and we specialize in the treatment of musculoskeletal pain and movement disorders. And if I could speak for our profession as a sole provider just for 1 second, I think the best way to summarize our mission as a profession is to reduce pain and disability while optimizing function and quality of life while utilizing evidence-based techniques. We try and utilize science to guide our treatment strategies. And those treatment strategies include therapeutic exercise, so using exercise as a tool and a medicine to help people improve, activity modification, which is, if someone has trouble doing a certain activity at home or at work, we can give them suggestions on how to modify that activity to allow them to still perform it and to maintain their independence. We also use manual therapy, different hands-on techniques to help people manage their pain. We can use muscle coordination training, which largely includes balance training for people who have balance impairments or who have had some sort of neurologic injury, such as a stroke, and now they need some coordination training to help with daily activity performance. And then, of course, the last thing is we help people with the use of assistive devices if needed, such as wheelchairs or canes or crutches and things of that nature. This was just a cool graphic from the California Physical Therapy Association, just showing some of the great things that physical therapy can provide for people, including restoring normal movement, for walking, standing, and running. We help improve people's breathing and cardiovascular function with exercise and specific techniques. We can help people prevent injury by optimizing their fitness and strength and flexibility, and many other things. I want to talk about this study real quick because it demonstrates the value of getting to a physical therapist early after the onset of back pain specifically. So this study was done by John Childs, who's a very prominent researcher in the world of physical therapy. And what they found was that if people saw a physical therapist within the first 14 days that they had the onset of a new low back pain episode, these were all the results. They had lower likelihood of needing x-rays and MRIs, which can be very expensive and expose people to radiation in the form of x-rays. It can decrease the number of people who needed to have back surgery. It decreased the likelihood of opiate use, which is a very big issue in today's world. It reduced lower health utilization costs. It was 60% cheaper, and there was a better pain and functional outcomes. So not only was it cheaper, but the outcomes were better, and people didn't have to have invasive procedures or surgeries and injections and things of that nature. So that's just a win for everybody involved. Another study that was done was looking at the chances that someone would be prescribed a high-level opiate medication if they had been treated by physical therapy first in their plan of care. So if they saw the physical therapist first, their conclusion at the bottom of the slide there, patients that received PT intervention at first line of treatment, they were 89% less likely to receive an opioid pain medication. And that is just fantastic news. The opioid epidemic has been a huge problem in the United States particularly, but in other parts of the world too. And it's just very unfortunate how many people are suffering. And it is a reality that recently among young folks, opiate overdoses has recently overtaken car accidents as the #1 cause of accidental death in the United States. And it's encouraging to see that there are other options for people who are suffering with pain, and PT is a great option to help people. This study is just demonstrating the value of PT to help people avoid having a rotator cuff repair. And what they found was in the 2013 study, up to 75% of people who had a full rotator cuff tear, not a partial tear, but a full tear, were able to rehab their shoulder without needing surgery. So if you had a partial tear, those percentages would even be higher, where you wouldn't need surgery necessarily. And this study showed that knee osteoarthritis surgery doesn't have to be your only option if you have a meniscus tear. And in fact, it's a lot of guidelines discourage people from having surgery as a first line of treatment if they have a meniscus tear. And this study showed that getting PT first helped 60 to 70% of people with knee OA avoid having surgery. Some other secondary treatments for muscle and joint pain, these things aren't bad things. It's just important that physical therapy is tried first. And so those other options include pain medications, injections, and surgeries. And again, there's nothing wrong with getting those things, and they help a lot of people. But we always want to try the most conservative treatment option first, because if someone can get better with exercise therapy and some self-management, that's fantastic. Let's give people control and allow them to kind of help themselves get better. And that's very empowering, and it's been shown to improve outcomes. Okay, now let's talk about some instances where if you have the new onset of pain, it might be important to seek medical attention quickly. So if you experience a fall or trauma at or around the time of the pain onset, it's probably a good idea to seek a physician, because they might want to order some x-rays to see if you had a fracture or a broken bone. If you're having any abnormalities in your bowel or bladder function around the time of the pain onset, you should see a physician as well. They might want to take you through some screening tests. If you have a personal history of cancer with the new onset of back or neck pain specifically, I would see your physician. If you have a recent infection accompanying the pain, it's important to see a physician. They could do some blood work to make sure that the infection isn't the cause of your pain. If you experience numbness or tingling in extremities or abnormal levels of weakness in your muscles, again, these things are very rare, but if you do notice them happening with your onset of pain, I would talk to your physician to see if they want to do any testing. And then again, if you have any difficulty walking or maintaining your balance, you want to see a physician as well. Okay. Again, I want to thank you guys for taking the time for listening to this lecture and investing in your health. I know this one's been a little bit of a longer lecture, and a lot of information has been thrown at you. But I want to leave you with this lasting takeaway message. And it's a quote from a man named Jeff Gilliam, who is a PT and a PhD in the world of physical therapy. And what he said was, if you were told that a certain pill could boost your immune system, lower the risk of heart disease, cancer, high blood pressure, diabetes, obesity, and osteoporosis, you might say, I'm interested. If I told you that same pill will also boost brain power, reduce depression, improve feelings of well being, and improve your endurance and strength without any negative side effects, you probably would be sold on taking that pill. And then ask, how much does it cost? What's the catch? That pill is exercise. Exercise has been shown to produce all of the above effects. And the best part about it, it's free. So again, I want just, if you take anything from this lecture, it's that exercise really is the most powerful medicine in the world, and that we have a lot of control over our health and our health outcomes, and that definitely includes our muscle and joint health. So just always remember the power you have and try and leverage those positive health behaviors of exercising and eating well and sleeping and managing stress and avoiding tobacco and excessive alcohol. If we do those things, we set ourselves up for success, and we're controlling what we can control. So again, thank you so much for taking the time to listen to this lecture, and I hope you found it very helpful. Have a great rest of your day. Thank you.